I'm going to call to order the joint CERS and KRS Retiree Health Committee meeting for September the 2nd, and we're going to begin with an opening video teleconference statement.
For the record, I want to note that this is a regular meeting of the Joint Retiree Health Plan Committee of the Kentucky Retirement Systems and County Employees Retirement System Boards of Trustees. This meeting is being held at the Kentucky Public Pensions Authority offices located at 1260 Louisville Road, Frankfort, Kentucky, and by video and telephonic conference, and is being broadcast to the public by Facebook pursuant to Kentucky Revised Statute Section 61.826. I ask if you are speaking and are not appearing by video, please identify yourself before talking. In the event the video or audio broadcast is interrupted, we will attempt to reestablish a connection. If a connection cannot be reestablished within 30 minutes, the meeting will be adjourned and rescheduled to another date.
Thank you very much. Roll call, please.
Mr. Piercy?
Here.
Dr. Miller?
Here.
Dr. Carver?
Here.
Mr. McGraw? That's it for the roll call.
Okay, we have a quorum. My understanding, Sandy, no public comment, correct?
That is correct.
Okay, and we'll move on to number 6, which is establishing the 2026 health insurance components and health insurance rate that will be used to define the 100% contribution for non-Medicare eligible retirees. And Connie is going to take this topic.
Did you all approve the minutes? I'm sorry. I just wanted to double check.
No, you're right. We didn't.
Okay.
I skipped right over that. Thank you. Let's do number 5 instead of number 6. Approval of committee minutes for May 15th, 2025, and I'll seek a motion.
I'll make that motion.
And second.
Okay, any discussion? Seeing none, all those in favor?
Aye.
Aye. Opposed? Motion carries. Thank you, Connie, and that's what I get for telling Nathan not to make any mistakes here.
Okay.
All right, Connie. Now I'm
Thank you.
turning it over to you for number 6.
All right. Just briefly, the Kentucky Employees Health Plan is the non-Medicare eligible plan that KPPA offers to the non-Medicare eligible or under 65 retirees. You can go on to the next slide, Sandra. They've offered the same 4 plans for the past 2 years, and most of the plans actually back to 2014. The plans are branded by the state of Kentucky, and the Department of Employee Insurance is the self-insured plan sponsor. Now, having said that, the premiums are confidential until September the 15th when they're filed into law through the legislative session in September. But I can tell you when we get to the slide, the cost increase. There is an increase in the premium. So the first plan I wanted to go over was the Kentucky Employees Health Plan, Living Well PPO. This is the plan you have around 20,000 or more actually retirees enrolled in. Majority of retirees stick to this plan because it has a copay structure for the doctor and specialist, and it has copay structure for the medications out of pocket part. So, in knowing that these deductibles and max out of pocket are going up 3 to 5% across the plans during this 2026 plan year. So it still covers the 75-25% split, 75% being the plan's responsibility, 25% the member's responsibility. The copays are $20 and $40. So the second a plan that's offered, and the retirees can choose from any of these plans. This Living Well PPO plan is the contribution plan the board has selected the past, I'm going to say, 10 years or so. Pay the next slide, Sandra. Oh, sorry, the Living Well. I was saying next slide, it's Living Well CDHP. Okay, this plan has an embedded HRA, so you'll be voting as that they're allowed to do that. It's funded by the premium in the plan, so there's no extra money for the HRA coming from the KPPA trust. The co-insurance, this plan does cover the 80/20. It has a co-insurance for medical and pharmacy and a deductible. That's what the HRA is supposed to help with, cover the expenses there at the very first. And then it's a catastrophic plan a lot of families like, because it'll end up paying for a lot of coverage. Once they max everything, then they get the plan paying the majority of their costs. It has a medical and drug out of pocket that's combined, meaning when you do a medical visit, it clocks off on the deductible for the drug as well. Next slide, Sandy, is a plan that has a little less coverage, 70/30. It does have an embedded HRA. That asterisk is a mistake. It just brings attention to the fact that there is an embedded HRA with this plan, and retirees can have that. It's a 70/30 plan, as I stated, and the deductibles are a little higher, and as you can see, than they were in the other plans. And that medical and drug benefit is clocking on the same deductible and out of pocket. Out of network, of course, would be a different rate for this plan. It is a commercial plan. So there is an out of network benefit that I really didn't mention. As you can imagine, on the benefit grid we give the retirees every year, it's posted on our website, and we send out a book. We do have that documented for them. The next slide. Now, this is the slide of the plan that is the high deductible health plan. You notice that it has that asterisk for the HRA there. I meant that to state that they don't have an HRA embedded in this plan. This is a plan truly for catastrophic coverage only. So it's got a higher deductible and out of pocket. And it's one that we have about 20 retirees in. It's the one that is the default plan. So the reason they don't have the HRA is because people that are using this plan default into it. And the EI felt like this is not a good use of that HRA to put it there, as these people don't seem to use a lot of their benefit every year. But they did add in the telehealth free for this option for 2026, which I think is the perfect thing because they don't have the HRA. So I feel like that's a positive for the people that get in this. They can get out of this plan the first month after enrolling, especially if they're a new retiree, and some of them do that, but it gives them the opportunity, if they're defaulted, to enroll in another plan because they're in one they don't like. Otherwise, they would have to go through an exception process. So it does serve a purpose as being a default plan. Next slide, Sandra. Now, there's a few benefit changes, and the big one, and not necessarily big on cost, because I'm not sure what the GLP, that's the one that they take, the patients are taking for diabetes, works to do that, as well as it works to help people lose weight. So they've done that. They looked at this benefit. They are still offering it. A lot of plans across the nation are no longer offering it. Some of the results are still positive. Some are looking at other side effects they're having. And I do know Medicare's backed off a little bit on paying for the GLP-1s for weight loss, but they're still considering it. So there is no change, though, for the two plans that are 70/30, the Living Well High Deductible Health Plan and the Living Well Basic CDHP. But these drugs are going to cost outside of, it's a special benefit outside of the drug benefit. So it's just for the GLP-1s. It's going to be the copayment deductible, then 25% coinsurance. Those drugs were running around $2,000 to $3,000 or more a year. I'm going to say some months, but I think, the diabetics are getting it for the lower copay of, well, it's still $40 if you have the Living Well PPO plan, but the other plans, it is a percentage as well. So that's how they're getting it in 2026. The drug right now is being given to them under a pilot with CVS, and we don't have the data back from that pilot yet, although I will bring it when we do have that result, because that will be a very good time point for them to see how this drug works in this population and see if the results are consistent. Emergency room is going to cost a copay and then a coinsurance for 3 of the plans. That Living Well Basic, that's the default plan, already has a 30% deductible, so it's not going to change. But the others are going to have a deductible for the ER as well as a copayment. Those are the benefit changes. Go on to the next slide, please. I don't think I have, well, there's the default plan, which we talked about a little bit, but it also doesn't access, Hinge Health is a musculoskeletal exercise program that supports people who have pain management issues. Carum Health is a support to cancer surgeries and other surgeries that there's a network you can get see a discount in, but so they don't offer those with that last default plan, but they do offer the telehealth, which is free to people on the KEHP plan. So telehealth is free for all the retirees, state employees, and it's been utilized greatly in lieu of going to the ER on holidays or when you have the flu, as well as things like ear infections, sinus infections, and just other things. They can prescribe what you need and get that so without cost to you from first dollar. So that's a good benefit to have with that default plan. And it's automatically used when someone fails to submit an insurance app as a new retiree or a mandatory open enrollment, which we do not have mandatory open enrollments again this year. If they wish to change plans, they can enroll. If they do not, they stay on the same plan and it will roll over. So the next slide, any questions? I know I'm going through this fast. I think most of you have been on the committee and are familiar with some of these. I think Dr. Carver might be our new person on this committee.
Yeah, but Dr. Carver uses the insurance, and so she understands.
Oh, she does. Okay, well, good. So you know how good of a benefit it is.
Yes.
Well, we work hard. I go down there every month, and we all try to manage, what retirees are doing and trying to make retirees and the state employees healthier. So here's the next step in that: tobacco use. The same one. They're continuing it, $40 if you use the tobacco. If it's a family or parent plus plan or couple, it's the $80, and that's been unchanged since I know around 2014. So we still have a certain amount of people that do report this, and we do have a small number that will take the smoking cessation classes and get off it through the paperwork. They'll get to waive the fee. So they can waive the fee by taking action during the year. So that's good news for those kind of things for the tobacco usage. Next slide, Sandra. And the Living Well Promise, that's where you have to take the health assessment now. It's no other venue but through Castlight. And basically you have between January 1 and July 1 every year to complete this promise. And it will give you the $40 a year the next year on top of your premium if you don't pay, you don't complete that. So if somebody failed to complete this year, 2027, they'll have extra $40 to pay. But I will take you that it's only the plan holder. If they're cross-referencing, then both of them are plan holders. And sometimes you'll have a retiree or a spouse on Medicare and the rest of the family on the KEEP plans through the non-Medicare. So sometimes that happens. So that's still going to be impactful to one plan holder to take this promise. And the next slide will tell you how we reached out to everybody. Sandra, the next slide. Thank you. Whoops. One more slide, I think, and then we'll go back to Nope, go back up, please. I thought I had, there it is. Yeah, that's it. We put it out in the new retiree books every year. We have the annual open enrollment materials that go out. We also have it on their website, social media posts throughout the year. Online KEEP enrollment application, it has that language when they're enrolling through the web. And also it's on any paper application as well. We did send a couple of reminders this year. We did April and then we did in June. We do targeted email blasts to the retiree list that we get from the Department of Employee Insurance that shows us the people who have not completed the promise and are plan holders for that year. So that's what we use to send these email blasts out. And so I feel like we've got a fairly robust notification, and we try to really capture those new retirees, because if they're coming in from a CERS plan, which about half of them do, they may not have this state plan as an offering as an employee. So this is new to them. But only during January. I mean, they have to be a new retiree January 1 for it to impact them. Otherwise, they get like an extra year. So I feel like that's the group we really need to notify the most, because the other people have been on the plan and doing this for a number of years now. I believe we're ready for the next slide, and this is where I was going to, cross-reference is still in place. They changed it last year to saying no new retirees or new hires that weren't in the CRIS system or on a Kentucky Employees Health Plan could have cross-reference. So we've not had really a lot of complaints about that. Some of them are looking at the fact that it might be better to just go through one employee's plan or retiree's plan instead of cross-referencing. It might be a little bit cheaper for them. So at least they're looking at options and making decisions, and that's what we encourage them to do. Cross-reference may or may not always be the best option for them. So that is still a benefit. It's a benefit that's only in Kentucky, and they're looking at it closely to see if it's a needed to continue benefit. Sandra, have the next slide, please. Here's the premiums for this year. There's an approximately 18% increase in these plans premiums. All levels, all plans are impacted. And I can't show you the actual premium until the 14th, but they will be in the open enrollment materials. We'll post them on the website as soon as open enrollment starts, which it starts for the non-Medicare eligible retirees October the 1st and runs through Halloween, October the 31st. Sandra, next slide. Here's your decision points for voting. I guess Mr. Piercy, I can kind of go through this, but it's the slide we used last year. It's got the 4 bullet points we need to vote on. And it's setting the contribution plan as well as the components for the hazardous duty spouse, dependent, and couple that get the contribution as well. It combines the tobacco fee as the option. It allows them to have the embedded HRA. It encompasses the Living Well promise. And I think I just briefly went over the first point there. And I think legal would let you roll all this into one, or you can vote on each number, ever how you.
So here's my question. It looks like we have to do we have a choice to make on the default plan, correct? It's one
Yeah.
or the other.
Yeah, you can set either one of those as your default plan. The one we, normally have checked would been that last one has been what the board's followed in the past, but certainly it's a pretty comparable plan as far as the benefits. I notice. So yeah, that's correct, Mr. Piercy.
So right now it's the high deductible plan. That's what we have in place.
Yeah, high deductible health plan.
Okay, all right. And then on number 4, it says we're setting the premium for the Medicare secondary payer plan.
Yeah.
But since we don't have numbers, how are we doing that?
We don't have any different premiums assigned by the Department of Employee Insurance, so you just vote as of number 1. You just include it as the same plan as selected in number 1. See, the thing is, if they decide at DEI to charge more premium for this MSP plan, there's 300 to 400 people in it. They rotate through the year. So if they decide that these people are costing more, they can charge us more for this small group than the big group. But they have not done that because the cost is the same. I mean, they haven't raised that Medicare secondary plan cost. The legislators let them put that in the law, 61 in the law a couple of years ago, that if they experienced increased costs, like let's say we had a couple of $1 million claims in there, which you could have with dialysis or something. Let's say we have some of that. Then that means that they may raise the premium on the plan the next year, and then we would have to set that premium differently. We have not had to take that action since the bill was enacted a couple of years ago.
Okay. So I have 4 motions in on my sheet, but this number 1 obviously has 5 different points.
It has components of the plan, yes.
Correct. But I think, I mean, I can't imagine we would go away from Living Well PPO as the contribution plan.
I don't see a rationale. You do have more people enrolled in that plan. Some people with family plans find it real effective to get that consumer-directed health plan that has the 80/20 coverage. But now the Living Well PPO costs a little bit more. Sherry can roll back to that slide with the premiums if you would like her to. I mean, Sandra. I'm sorry, Sandra. Please forgive me.
And Connie, I was going to mention that you might want to show the next slide that
Okay.
has the number of
Yeah,
retirees who are
that'll help
enrolled in
too.
each plan. That might be helpful too.
Yes, just I guess roll down then, Sandra. Yeah, see, there's your spread of, you see that, and those people were defaulted the 24, and we try to reach those people. Some people just want to stay on that and they'll just default, but it's less than it has been in the past. But 24 is, and then you see the ones that have selected the basic CDHP are around 900 people in 2025. So I'm not sure that helped.
So on back to page 19, I think 19 to 55. Yeah, there we go. Everything that's in number 1 is the recommendation, correct?
Yes, that's what you
Okay.
followed the practice over the previous years for the reasons you have, and it's logical, I believe. You're
Okay.
listening to retirees about co-pays and co-insurances for, they feel comfortable with that, although we are seeing some and they ask about the other plans, but they do that slowly and individually, I think.
All right. So is there any more questions or discussions on Connie's presentation? And if not, I will seek a motion to approve the health insurance components as recommended on the board decision point slide there under heading number 1.
I'll make that motion.
Second.
Okay, any discussion? Seeing none, all those in favor?
Aye.
Aye. Any opposed? And that motion carries. And then the second, I'm sorry. Somebody have something? Okay. Second one, is there a motion to approve the default plan for 2026, which is what we'll be carrying over from 2025, which is the high deductible plan. Is there a motion to approve the default plan for 2026 as recommended?
So moved.
Second.
Any discussion? All those in favor?
Aye.
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 Any opposed? And that motion carries. The third motion is there a motion to allow the cross-reference option for retirees during the 2026 open enrollment as recommended?
So moved.
Second.
Any discussion? Seeing none, all those in favor?
Aye.
Aye. Any opposed? And the motion carries. And the final motion is to set the premium for the KEHP Medicare Secondary Payer Plan at the rate recommended.
I'll make that motion.
Second.
Any discussion? Seeing none, all those in favor?
Aye.
Aye. Any opposed? And that motion carries. I think that's got that section, unless somebody tells me we've got more to go.
No, I just want to tell you one fact, Mr. Piercy. This
Okay.
is the Department of Employee Insurance is out to contract. They have an RFP out that should be completed the 15th of September for the pharmacy benefit. Now, that's just a provider, because this benefit belongs to the state of Kentucky. It's been it's went through the branding process. So this is KEEP's formulary or drug benefit, but they are still in last negotiations with the provider, which is part of why the premium can't be released. And then, all of that ties into that when they have to go to legislators on the 15th to report all of those activities. So that's the only last thing. I didn't want you to leave you with that if it suddenly is not CVS Caremark. Although it still may very well be, but they are not released. They can't release. It's a state bid under 45A. So, and then we just have general information on the slides, kind of how in the appendix where the statutory language about the plans being offered are captured, and things that, they're saying the utilization is going up. I agree. And the drug cost is going up. And you're going to continue to hear that story as you see on the TV and as you hear from us. That's what the forecast is looking like for the benefits going forward for health insurance in the United States. So that's all I have, Mr. Piercy. Sorry.
Right. No, thank you very much. Okay, we are now up to the 2026 health insurance components and rates for the Medicare eligible retirees. And Connie, are you going to kick this one off as well?
Well, just to introduce Humana as our vendor or our insurance plan for the Medicare eligible retirees. And this does include disability retirees who have Medicare because of disability as well. So there's around 65,180 when payroll ran enrolled in Medicare plans, but you're going to see different numbers because Humana is going to report on the Medicare Advantage enrollments. Just know that we do have our own self-insured plan, and briefly we'll talk about that, but there's about 4,000 or so enrolled in that plan. So I'll let you have Humana. Is it going to be Tracy Garrison, our
It
account management
is.
team?
Yep. Yep.
Morning,
Myself
Tracy.
and also Larry will be speaking to some of the slides as well. And if you're ready, I can also let you know Carla Whaley, I think, is on the line, although I think she needs to drop soon. And then we also have Holly Bliss and Gary Gillette from Actuary and Underwriting, should there be any detailed questions that need answering. All right. Thanks everybody for inviting us here today. We will be presenting as Connie said, the 2026 rates for your Medicare Advantage plans. If we can go to the next slide. We'll spend a little bit of time talking about just how the rates and the plans are changing for 2026. Talk about a few other changes that are coming, and then we'll get into the details about the renewal rate and just touch base on the renewal exhibits, which Connie has access to. So with the next slide, I'm going to turn things over to Larry to get us started.
Thanks, Tracy. Good morning, everybody. If you want to go to the next slide. So as we think about how we arrive at the rates that are charged for these Medicare Advantage plans, on the screen there, you can see those different factors. So we, of course, incorporate the medical and pharmacy claims trends, the benefit changes that might be considered. Important in the Medicare segment is any changes from CMS. So we reported in prior meetings the year-over-year changes that we saw in the final rate notice from CMS back in the spring. So basically, we roll all of those factors together, and that dictates, what the final rate is that we charge to KPPA. If you want to go to the next slide, there's really, the big story this year, and Connie sort of alluded to that in her comments. The big story here is really twofold. One is the Inflation Reduction Act and the effect that has on plan costs and plan utilization. And then simultaneously, we're seeing rising drug prices driven by high utilization, and the introduction of new specialty medications. So we are anticipating for the coming years to see higher costs for plans like KPPA's, Medicare Advantage plans, due to those factors. For the Inflation Reduction Act, we've reviewed this in many a meeting with you all. As a reminder, the most significant component to that was the change for 2025 that lowered the maximum out-of-pocket costs to $2,000 for plan participants. So that mandated benefit enhancement shifted cost to the plan sponsors, where they are now responsible for a much larger share of catastrophic drug costs. We're going to show you some details in a subsequent slide about the sort of, where rubber meets the road. What did it actually mean for your members? We're seeing less CMS reinsurance to offset those higher specialty costs. And then, as I mentioned, that is an enhancement for your retirees. So if I'm a retiree listening to this call today, my benefit got better in 2025 as it relates to the drug benefit by lowering that out-of-pocket maximum. We are simultaneously seeing, as I mentioned, rising prescription drug prices, notably for specialty medications, cancer drugs, diabetes medications, and we expect that will drive higher pharmacy trends for really the foreseeable future. One interesting component to this that we're watching closely is as retirees hit that lower maximum out-of-pocket cost, where they then have no out-of-pocket costs for their medications for the remainder of the year. What does their utilization look like? It could be that we see changes to sort of buyer behavior once there's no financial hurdle in place for the retiree. So those are the two big drivers of utilization that we've seen. For KPPA, that is definitely the case. And in fact, we've seen even higher specialty drug utilization for your population than what you would sort of consider an average population. So if you go to the next slide, this sort of details the changes that I mentioned on the Part D cost shares. So for 2026, the deductible, this is the standard CMS required benefit. That deductible goes to $615. That this is only in place on the essential plan, but we track this behind the scenes, even on the premium plan. you can see that the out-of-pocket threshold was it was at $8,000 in 2024. It lowered to $2,000 in 2025, and then the law indexes that up to $2,100 for 2026. The actual benefit in place for the essential plan, for those of you who've been around for a while, you'll recall that we held KPPA elected to hold that deductible at the 2020 benefit level, which was a $435 deductible. And so we've assumed that that will stay the case moving forward. Go to the next slide. This is a lot going on the slide here, but what we wanted to draw your attention to are a couple of data points. I mentioned the improvement to the drug benefit via the maximum out of pocket. So if you look at sort of pre-IRA and post-IRA, the top section of the slide for 2024, when the maximum out of pocket was $8,000, you had 5,321 members hit that maximum out of pocket by the end for the full year. Through June of this year, as that MOOP, as we call it, was lowered to $2,000, so it went from 8 to 2. By June of this year, you've already had 9,700 members hit that maximum out of pocket of 2,000, and therefore they have no further drug costs for the remainder of the year. We expect that 9,732 by the end of this year will be north of 18,000 KPPA retirees with hitting that maximum out of pocket. There's also a unique wrinkle to the way that $2,000 is calculated. So it's really not a $2,000 maximum out of pocket because of the nature of this group sponsored drug benefit. The actual out of pocket cost for those 9,732 members was only $471. So great benefit for the retiree, especially, retirees not getting a big pension check potentially. I mean, these are definite enhancements and improvements to the benefit for them. But it highlights the cost pressure that is on the plan that we are having to account for. Any questions about anything on that slide or the prior slides? Okay, I'm going to turn it back over to Tracy, who I think is going to finish us out on the rating details.
Thanks, Larry. A couple of things before we get to the rates. If we can go to the next slide. There's a couple of things I wanted to draw to your attention just to make sure everybody was aware. Humana has announced cuts to our prior authorization requirements, which I think is really fantastic news for our members, your members, and also for the physician community. We'll be working over the next year or so to really reduce the red tape related to a lot of authorizations. We will be reducing by January of this year of 2026. Humana will be eliminating about 1/3 of the prior authorizations required specifically on outpatient services. So really looking at how physicians are responding today and what they're providing and making sure that the things that do require authorization really are appropriate to require that of them. We're also working to improve the turnaround time on authorization requirements. So we're streamlining our processes. And again, by the first of the year, we are making a commitment to reply to the majority of our authorization requests within 1 business day. So about 95% of our authorizations, we are committed to replying within 1 business day. The ones that are going to take longer than that will be those that are more complex in the decision that is required, may need physician review, that kind of thing. And then lastly, as we go through 2026, Humana will be creating a gold card program for physicians, looking at their historical performance as far as authorizations, and if generally they're providing full data requests to us or fulfilling those requests first time around and submitting everything and receiving an authorization, they will qualify for the gold card program and then will not need to provide authorization requests for most of the procedures that they do. So exciting opportunity, I think, for our physician community. You know, we're hearing from them that they would like to streamline things. And then, of course, you know, a one-day turnaround on the majority of those things that do require authorization for our members is certainly going to be a real positive change for them. So exciting news there. And then we've got one new benefit that's coming that I wanted to make everybody aware of on the next slide. This is a ride share benefit. So Medicare allows Medicare Advantage plans to utilize this uniform flexibility benefit, which I think is kind of an odd term. But basically, what that means is we can target specific types of members' diagnoses and provide a specific benefit for them. So in this case, members who currently have diagnoses of chronic kidney disease, end-stage renal disease, or cancer will have the opportunity to access transportation benefits through this rideshare service. It is car, van, wheelchair, accessible, etc., at zero cost share to them so that we can ensure that they are getting to their doctor's visits in a timely manner and providing that support because we know that it is critical for them to get that care that they need. So that'll be a benefit enhancement at no additional cost to the member. All right, now we can get into the exciting rate conversation. Let's go to the next slide. We're going to start by talking about the premium plan. And you can see on this report, this is just the claims report that was used at the time that we provided the renewal based on. You can see in the lower right-hand corner here, 98.1%. That was the average loss ratio for this 12-month period. So that is, you know, higher than what we'd like to see. But the, you know, the good news is we do see a decreasing trend there. So we're optimistic that as we get into more of 2025 and then into 2026, that we'll see some stabilization of the loss ratio for your claims. Next slide. And feel free to interrupt me as I go through this if you have any questions. So these are the renewal components for the premium plan. So this plan has the majority of your members on it. I think it's about 58,000 of the KPPA retirees do take the premium plan. Just as a reminder, the premium plan and the essential plan have the exact same medical benefit. So the difference in the options for your members is on the pharmacy side. And Larry kind of alluded to those benefits a little bit. The premium plan has copays, no deductible, very consistent benefit. And then the essential plan follows more of the standard benefit. It does have the deductible and then a 25% co-insurance once they get into that. So just wanted to remind you of that. This is the premium plan, so it is the richer of the two benefits. Humana is showing total required revenue of $1,447.13 per member per month for 2026. That is based on claims projection, with claims projection of $1,463.42. Humana's retention on this plan is $56.04. And then you'll see here the Humana business decision retention reduction. So we are reducing that amount by $72.33. You know, we do want to work with you over time to get back to really a more sustainable level of profitability. But we are not trying to get back to the days of when we were providing significant gain shares back to KPPA annually. In fact, that's probably not where, you know, we ultimately want to go. We want to get the premium at the right level. But as a lot of the things Larry talked about are coming into play and we're making adjustments on that, we also want to be, you know, a good partner to KPPA and your members and kind of easing into that adjustment over time. And also giving your members an opportunity to adjust and kind of see how they will behave in this environment, specifically with those pharmacy benefits. So that is why we did put that business decision retention reduction in for 2026. Of course, the projected claims reimbursement from CMS has a significant impact on the overall premium. The medical reimbursement from CMS is projected for 2026 at $1,151.46, and then the pharmacy reimbursement is projected at $95.73, which then brings us to the $199.94 premium for the premium plan for 2026. Questions on that before we move to the essential plan?
It's currently at 144. I forget, 144.
It's actually several slides in here. We'll look at
Oh,
that.
you've got it.
We'll look at the year-over-year comparison in just a minute. Okay, next slide. All right, so this is the essential plan. About 4,000 members are on this plan, 4,000, 5,000 members on this plan. The lower, less robust pharmacy benefit on here. And you can see this plan performs significantly better from a loss ratio perspective. The average 12-month rate loss ratio for this plan is 93.05. Next slide. Looking at the same information on this plan as far as the renewal components, the total required revenue on this plan is $1,151.85, with projected claims at $1,067.80 per member per month. We've got retention at 84.05 on this plan. Due to the performance of this plan and the way that it does perform, there was no need for any type of business decision or retention reduction this year. And then we're showing projected CMS medical reimbursement $1,028.53, with the RX projected reimbursement at $68.22, bringing us to a premium on the essential plan at $55.10. If you want to go to the next slide, we'll be able to look at the year-over-year comparison. So on the premium plan, obviously this isn't every year or way back to the beginning. I think it was 2013 when we started offering benefits to KPPA. But looking at 2022, which was the last year before we had the RFP, we were at $227.03 for the premium plan amount. And then you can see beginning in 2023, we did have a reduction. This was with the RFP at $89.28, trending up slightly, $93.35 in 2024. And then last year, with the significant changes to the pharmacy benefits, we had a significant increase up to $144.91. And then this year continued to the $199.94. Looking at the essential plan, I mean, you can see in 2022, we were at $49.25. With the RFP, we offered a 0 premium on the essential plan, increased that to $407 in 2024. And then we were able to go back to a 0 premium on that plan in 2025. But we do see an increase this year for the $55.10 per member per month premium. Questions about the renewal rates? All right, I think we can go to the next slide then. Included with the renewal, Humana will continue with our commitments, the financial commitments over and above the premiums. So we will continue to offer a gain share should the plan perform, at a set level beyond what we are estimating. Humana would share in those profits with KPPA. And then we also have performance guarantees in place, the same as we've had for the past several years, issued and provided through the RFP. Next slide. This takes us to the ASO fees, if we're ready to get into that. This is for the medical only and the MIR plan. These are your ASO funded plans. Humana provides the benefit administration, so we process the claims. And then also provide additional, well, not provide, but for members who want or need their pharmacy benefit, we provide the PDP pharmacy benefit. So for the medical only MIR plan ASO fee, the per member per month fee on that is the same this year as it was in 2025 at $31.37. We add dental coverage on the MIR plan because we do offer dental coverage on the Medicare Advantage plan. So the premium for that is also the same as it was in 2025 at $5.29. And then if a member is on that MIR plan and they choose the pharmacy benefit, they have a choice between the essential plan and the premium plan. The premium for the essential plan is $65.04 for 2026. And then if they were to elect the premium plan, they would have a $205.15 premium on top of the medical benefit. All right, questions on that? All right, that really, that wraps up what we had prepared. There is one additional slide, I think in the back if we want to go to that, and I'll just review that real quickly so you know. Next slide. Humana does provide detailed information over and above what you've seen here today. Connie and Aaron and the team at KPPA have access to all of these reports. So if you are interested in any additional detail, please know that that is available. Questions on the renewal before I turn things back over to Connie? All right, thank you.
Mr. Piercy, we probably need GRS, Danny White and team to go over the letter on, I think it's, well, it's in my thing, it's page 52, but I think it's right after the voting slide. Sandra, if you could go on down, keep going.
52 is correct.
52 is correct.
Uh-huh.
Okay.
Yeah.
Thank you, sir.
Morning. Michael Reed, are you on and can speak to this?
Yeah, Danny, I'm here.
Thank you.
All right, yeah, these are the premiums that cover the medical only plan that Connie had discussed earlier. This is based off 2024 experience, which for these people had about average expected claims this year. So there's only a slight increase of 1.4% just to the medical portion of it. Once you combine it with the rates from Humana, the pharmacy benefit adds the $56.58 for the essential plan and $57.79 for the premium plan. Scroll down to the next page. You can see the table here shows the increase over last year's premium. It's just a slight increase for the medical only plan, and then the bulk of it, once again, was just from the premium rates from the pharmacy, which, like the Humana team covered, highly driven by the IRA changes going into this year and then continuing into next year as the experience shows.
You have any questions of the actuaries, Danny or Michael, and maybe Aaron? I'm not sure at this point. Is that where you want the impact to be gone over? Janie, I think, worked on that. It's the impact of the premiums 2025, and it's right after this letter. I wasn't sure where you wanted the impact discussed.
I think it'd be appropriate to go ahead and discuss it
Now-
now if GRS can
Thank you.
do that.
Very good. Jane, you feeling up for this one, or you want me to take this?
Yeah, that's fine. I can go over this.
Okay, thank you.
So as the board knows, we have the June 30, 2025 actuarial valuation coming up. That valuation will take into account the 2026 Medicare premiums as well as the pre-Medicare premiums. So we just wanted to give you an idea of what the Medicare premiums, kind of an idea of the impact that those are going to have on the actuarial valuation results. So as you know, the Medicare premiums are quite a bit higher than we were expecting. They increased about 38% versus we were expecting about 8%. So that's a pretty big jump, pretty big increase in the liability from what we were expecting. So if we look at kind of what that impact is going to look like, so in terms of liability, so across all of the funds, the insurance funds, that's going to be a $659 million increase in your unfunded liability just due to the Medicare premiums. If we look at that on a funded ratio basis, so your K-HAS and your C non-HAS funds, those are still going to stay above 100% funded. But we do expect the state police and the C-HAS funds to fall below the 100% funded this year, but they will stay above the 90% funded. And then, of course, the K non-HAS will still be below the 90% funded. In terms of employer contribution rates, so the K-HAS and the C non-HAS, those are still quite a bit funded. So those insurance contribution rates are still going to stay below 0%. So that's why you can see there's no impact on the employer contribution rates because of the Medicare premiums. But if we look at state police and C-HAS, that's about a 2.1% increase as a percentage of payroll, and C-HAS 1.1% as a percentage of payroll. So again, across all funds, we're looking at about 34 million increase in annual contributions just because of these Medicare premiums. Again, the bulk of that coming from the K non-HAS plan. That's about 23 million increase in your annual contribution. But again, I want to preface this by saying this is just isolated to the Medicare premiums. Again, when we come back in October and start talking about the June 30, 2025 actual evaluation, which is what's actually going to set your employer contribution rates. Again, that's going to take into account a lot of different things, not just your Medicare premiums. It's going to take into account your pre-Medicare premiums. We're also going to see some asset gains this year that's going to offset some of this. So there's going to be a lot of things that are going to come into play in that valuation. This is just the isolated impact of those Medicare premiums. But we can definitely take any questions from the board on this.
We have a question. I'll just say that, this is just 1 year and these funds are in pretty good shape. So we can absorb these types of losses for 1 year. The problem is if it extends 3, 4, 5 years, then you may turn around in a few years and say, uh-oh, now we've got to figure out a plan to get our funds shored back up. So, an 11.5% loss in one and a 10% in the other. I mean, those are over 100% funded, so it isn't that big of a deal. But like I said, if it happens in a few years continually, then we end up in a situation that's not at all unlike our underfunding situation, where if you miss funding 1 year, you may be able to take it. But if it goes 16 out of 20, you're in deep trouble.
That's 100% correct. And we are working with Humana to try to get out in front of, try to get a better idea of what those future increases are going to be. Obviously, we can't 100% predict what the increases are going to be in the short term, but we are working with Humana to try to get a better idea and try to build that into our valuation to try to smooth out these increases. Because as the board may remember, we did have a big increase last year as well. So we are working with Humana to try to get out in front of that.
Thank you. Any questions or comments for the GRS folks? And if not, thank you guys. Connie?
We need
Thank
to
you,
go
Janie.
back to the voting slide, 51. And yes, thank you, Danny, Janie, and Michael. Appreciate your all's input and assistance. So here's our slide that we're going to vote next for the Medicare plan. So we want to select a contribution plan, and we want you to look at selecting the Medicare Advantage premium plan for 2026. That premium is $199.94. Last year you chose the medical only plan only because it met the criteria and its rate was 191, and I think the Medicare Advantage premium plan was under that amount. So we're recommending that you change it to the contribution plan to be the Medicare Advantage plan, premium plan, and set at $199.94. And then the medical only plan would be, as GRS's recommendation would be, it's actually the medical only plan. That's a mistake. It's not 194. It's 190. I mean 199. It's 194, as Michael had on his slide. So as you can see, by selecting that Medicare Advantage premium plan, it's going to allow it to pay for the essential plan at 100%, and the contribution for the medical only plan would also be covered.
Yeah, the
Essential
medical only
plan.
plan is 194.23.
Yes, sir. I'm sorry that I got it wrong on here. So yeah, it's 194.93.
23.
23. So the premium for 2025 would be, as stated by Mr. Piercy, then it would be for the Medicare Advantage premium plan, $199.94, and the essential plan is $55.10. So those are their costs. The benefit premium, as stated by Mr. Reed on his slide, is what would be the mirror plans to follow. And then the medical only plan has been the default plan you selected, because if someone chooses to enroll in an MA plan, it will take them out of our MA plan. And if they want that plan and we default them into something similar, then Medicare will only give them the one, and we would have interfered with what they're trying to do. Medical only plan won't interfere if they have enrolled in an MA plan, and then we can coordinate with them to cancel that if they don't need it and they're enrolled in another plan. But it allows them to have coverage, because Medicare does penalize them for not having their coverage through Medicare and engaged when they're 65. So that's the vote for this. You're allowing the mirror plans for the reason of exceptions. If you have someone who's in another transplant network, which we did have one, and so they get to stay in the plan. They use the mirror plan. Medicare pays as primary. Humana or Personify pays as secondary, and then the drug benefit is the Humana prescription drug plan, and that covers as well, actually, because that plan won't, or that provider will not bill Humana. And that would be the reason. No existing coverage available. This is maybe a specialty procedure they have to have. It's only at one place. It's not experimental investigational. So there's criteria that actually is a little bit more specific around those. We only have 2 on the mirror plan, with the exception right now because of providers not being available. And there's somewhere under 90 that fluctuates throughout the year because they may or may not have their Part B at time of retirement. So you can vote for selecting these options altogether as you did previously.
And I'm just going to once again restate that under the recommendations under heading 1, which is on page 51, the medical only rate is not 199.94. It's 194.23. So the recommendation stays the same. It's just the amounts slightly different.
Wait a minute, Mr. Piercy. If you set it for 194, that means people on the premium plan would only get 194, and they'd have to pay out of pocket the rest of that.
Okay.
So that's why, we got to flip back.
This about every year, and I seem to not remember until it's too late. We have to keep the higher amount, or folks have to pay out of pocket. So the 199.94 is correct after all.
And recommend for the MA Medicare Advantage premium plan for 2026 is the contribution plan.
Okay. I got you. Okay. So we have 3 motions. The first one is there a motion to approve the Medicare Advantage plan, including approving the premium/contribution rate, approving the contribution plan for hazardous duty spouse and dependents, and approving the premium for the Medicare Advantage premium and essential plan for 2026 as recommended?
So moved.
Second.
Okay, any discussion? Seeing none, all those in favor?
Aye.
Aye. Any opposed? And that motion carries. The second motion is, I'll seek a motion to approve the medical only and Medicare Advantage mirror plans, including approving the premiums and allowing enrollment for no Part B and certain exceptions as recommended.
So moved.
Second.
Any discussion? Seeing none, all those in favor?
Aye.
Aye. Any opposed? Motion carries. And then finally, is there a motion to select the default plan as recommended, which is the medical only?
So moved.
Second.
Any discussion? Seeing none, all those in favor?
Aye.
Aye. Any opposed? And that motion carries. Connie, I think that's got it covered, does it not?
Yes, sir. I believe
Okay.
so. And you may have other business, I think, on the agenda next.
Sure, we do. Okay, thank you very much. Thank you to the Humana folks. And we have other business. I know Aaron wants to bring a couple things up.
Thank you. Two items. One is an update on a previous item and one is a new item for discussion. First, I just wanted to give you an update on the Kentucky Group Health Insurance Board representative that is required by statute. As a reminder, we brought that to the May meeting. There were no committee members who were interested in serving as that representative. We took that memo to each of the full boards to see if any other trustees had interest, and there was no interest there. Connie has been working on a recommendation to present to you all. There are still a few outstanding questions with DEI. Once we have those answered, then we will bring that information back to you at the next meeting. Connie will continue to serve as proxy in that position. The next item is pertaining to the next retiree health plan meeting, which is October 23rd. It's scheduled for that date. As the trustees are aware, the KPPA is hosting the Impact Forum. That is going to be held during that same time. Those dates were chosen based upon the whole trustees, both the CERS and KRS board availability. That was when the trustees were most available to be able to attend. So because of that conflict, we're bringing to you today some options for that meeting. You can either decide to reschedule that meeting, or if you all think that it can be canceled, then you also have the option of canceling the meeting. So typically during that October meeting, what we bring is some open enrollment stats. Really, we don't have a lot of open enrollment stats at that October meeting because open enrollment starts October 1st, and the Medicare open enrollment hasn't even started yet. And then Humana usually brings some of the pharmacy changes that will affect some of the members in the following calendar year. There are typically no items that are voted on during that meeting. It's informational. But again, we can bring those items at a later meeting if the committee decides to cancel. So opening that up for discussion.
There's nothing that's really pressing, I'm good with canceling the meeting and just bringing those items up at a later time.
Agreed.
Okay,
Okay.
so let's just proceed that way, and we'll take that up at the next meeting.
Okay, that sounds good. Thank you.
Okay, any other business?
I just wanted to thank the board and committee members for participating and to let you know what I was telling Mr. Piercy when I first got on. The retirees appreciate what you're doing. They tell me how they like and don't like very directly the plans as I go out during open enrollment. And I want you to know Louisville was one of my hardest barriers, but I have to love Louisville now because those people are so nice and they're so eager to get healthier. I've noticed that working with them, and they've combined their two groups together in one of them. But I just wanted to brag on, and even all the way to Somerset and Ashland, and I'm hearing they appreciate staff and the board members that represent and help them with these benefits. So thank you.
Any other business? And if not, that we've reached the end of our agenda today. I appreciate everybody attending, and we are adjourned. Thank you very much.